عايز اطول عليكم، انا سعيد جدا بان انا معاكم مره ثانيه. في بس هنحاول cover quickly التوبكس اللي هنتكلم فيها. كلمه dementia, diabetes, then we're going to end up with ethics medicine. The American College of Physicians recently issued, after setting a marathon, they have a paper or issued a statement about update to the ethics manual. So we try to touch base with that too. Especially we need it now. There is a major change in how we serve patients. Healthcare is a service. It's not a production. We don't produce anything. We serve.
دكتور patient relation. المفروض الاسكس ما بتتغيرش. فابديتنج دي عامله زي الجنريشن الاولى والجنريشن الثانيه.
We'll see. الأول we're going to start with dementia. We'll try to cover that topic. What we're going to try to cover, definition, types, etiology, diagnosis, management, prognosis, caregiver burden, and resources for dementia patients and their families. Definition is a clinical syndrome in which multiple cognitive domains, including memory, language, patient skills, judgment, and problem solving are impaired to a disabling degree. Okay. Causes. Let's start with first reversible, irreversible, non-reversible, metabolic, hepatic, uremic encephalopathy. I'm just going to stop here for 1 second, okay? For hepatic encephalopathy, can someone enlighten me? You have a patient coming to you with hepatic encephalopathy. What do you think and how do you treat him? What do you do? You see a lot of liver patients, right? So, patient comes to you in the clinic, you're admitting him, you're diagnosing him with hepatic encephalopathy. What do you think that could be the etiology? What brought in the patient today and how do you treat him?
لو عنده spontaneous bacterial
It should be interactive.
بشوف حضرتك لو في عنده spontaneous bacterial peritonitis، لو كان في اسايتس، كان في ريجيليتي وعنده فيفر، فبشوف ان ممكن يكون عنده spontaneous bacterial peritonitis. بنحاول ان انا
infection.
infection. في برضه
هو البريسبيتيتنج كوز، البريسبيتيتنج كوز البريسبيتيتنج كوز وبعدين ابدا عالي.
لو في برضه عنده
starting broad spectrum antibiotic.
تمام. لو في برضه
Like what antibiotic usually.
يعني احنا بنحكي كلافران في بعض الناس بتكتب مترونيدازول بس هو ريسنتلي قالوا ملوش اي رول. مترونيدازول فلاجيل 500 كل سنه. و في برضه بتبتدي فاكتورز اللي هو لايك انستليشن.
احمد ده السبونتينوس بكتيريا بيرتونايتس. هو السيفوتاكسين اللي هو الثيرد جنريشن كيفالوسبورين ده الاساس. انت قلت الميكرونيدازول مش كده؟
لا ما حضرتك بقى في ديبي فدلوقتي حاليا قالوا خلاص ما فيش منه ملوش رول يعني. بشوف حضرتك برضه البريسبيتي فاكتور لو في عنده كونستيبيشن. الكونستيبيشن تمام. لو في عنده قلق بندي حضرتك هنا لاكتيلوز بندي مع درجة تطلع وبندي انيمات طبعا مع لاكتيلوز برضه.
انيما؟
لاكتيلوز وبندي
I'm sorry. Which enema you get?
وهنا عندنا حاجة تراديشنال انيما ان احنا بندي الملح اللي هو الصلاين مع اللاكتيلوز وبنديه كل 8 ساعات بالجهاز الانيما العادي خالص.
انيما وز لاكتيلوز او وز نيومايس.
بشوف برضه حاجه اي بريسبيتي فاكتور مثلا زي لو في عنده الكترولايت ديستربنسز في بوتاسيوم او صوديوم او كالسيوم او كده بحاول اظبطه له وبندي حاجات بقى حضرتك اللي هي بتكاونتر اكت الامونيا في البلاد زي الهيباميرز بنديله اي في او بنديله ساشيتس بنديله
بتشوف كتير patient third spacing volume loaded they still dehydrated.
طبعا
because of the diuretics.
بيجي هايبرتريميا ممكن الصوديوم بتاعي ب 120 والسكين ترجع طبعا فيري راف سكين
بتعمل له البيشنت جاي with hepatic encephalopathy, volume depleted but he's sort of spacing. What do you do?
بنشوف حضرتك لو في عنده سيرت سبيسنج يعني في اسايد ستنس قوي.
بتعمل دايوريتك توقفها؟
حضرتك بنوقف الدايوريتكس طبعا بيكون وهو داخل في انسفالوبسي، لما نوقف الدايوريتكس عشان طبعا دي بتبقى ريستريتنج فاكتور ان انت داخله في الانكفالوبسي. وبنحاول بنحاول بقى نظبط الالكترولايتس كالصوديوم وبوتاسيوم وبنديله فلويدز.
اوكي.
وبنشوف كميه البروتين لو كان خد كميه بروتين اكتر
طبعا بنعمل ريستريكشن للبروتينز طبعا.
الالبومين؟
بنريد حركه الالبومين بالظبط، نديله الالبومين وندي حركه ليفر سبورت، ممكن نديله ليفر ابيمين او اللي هي الفيتامين اي والمالتي اللي هو المالتي فيتامين اللي فيهم لو عنده مثلا فيروس سي نديله سيلمارين.
احنا بنيجي كده كمان كنت قاعد ساعات العيانين دول بيجوا بكتيرينا سيندروم. احنا بنديهم ميدودرين، ساعات بنديهم اوف
دوبامين. دوبامين.
فندم؟
مفيش دوبامين في البكتيريا.
بندي اكتر ميدودرين
هو ايه الاكشن بتاع
ميدوكلوريتايد. دول have more studies proving to have effect. بصراحة يعني أنا شغال مع liver team, transplant team. I'm working with the liver transplant team, St. Luke's Hospital. The success rate for the liver transplant is 100%. Very meticulous and for the peritonitis, spontaneous bacterial peritonitis, we look for the broad spectrum antibiotic. Usually we give alternative choices like Herceptin, levofloxacin, cefepime, broad spectrum antibiotic. We try for white coverage. This is one. If you think of constipation as a cause, non-compliance, or patient taking the electrode but not similar, the same problem you have with the patients here, we have the same problem there. Okay. So we give them the electrode and usually that solves the problem. We try to avoid enemas. If we give enemas, we give water enema. We also see commonly cardiac complication. Sometimes the patient has failures. So that's another reason to try to avoid enemas. I haven't had a patient who had surgery. We try to work it out with them slowly. Very conservative with these patients. Bleeding. I haven't seen a patient who died, liver patient who died from bleeding. We give them return drip, give them bactericidal drip. The gastroenterologist intervene in time. Banding. Ligation, and usually the patient survive. And usually the patient goes home in a few days, 3 days. Going back to the other causes for the dementia, chronic encephalopathy, hyperthyroidism, vitamin B12 deficiency, folate deficiency, stroke, seizure, normal pressure hydrocephalus, infectious, bacterial, fungal, viral, syphilis, HIV, Lyme disease, Creutzfeldt Jakob disease, toxic drug effects. There's a wide array of medications. We'll come to that. Alcohol. We know about delirium tremens, chronic encephalopathy, traumatic post-traumatic, and it's equally psychiatric, acute schizophrenia, chronic psychosis, bipolar disorder, neoplastic, meningeal carcinomatosis can cause delirium dementia. Irreversible like Alzheimer, vascular dementia, frontotemporal dementia, Lewy body dementia. So what is normal pressure hydrocephalus? Diagnosis mainly is clinical, triad, dementia, gait abnormality, urinary incontinence.
أعتقد urinary incontinence بتبقى social يعني بتبقى urinary inappropriate يعني حاجة في أمور ولا social يعني واحد يتبول في حتة في أي حتة في أي توقيت بتاع مش كده لكن مش incontinence بالمعنى بتاع المساج.
لا بالمعنى بتاع المساج. always يكون كنترول
ولا هو عنده كنترول بس inappropriately يعني ده social.
يعني مش كبيهيفير. هو
مش
اورجانيك
behavior disturbance.
اورجانيك مش
فاهم حضرتك أنا أقصد إيه إن هي
أنا أقول لك إحنا we'll come to that in a minute. Imaging, you do a cascade, you see ventricular dilatation, and increased ratio ventricle to cortical ratio. It's not really reliable. Sometimes can be tricky, and could be a late sign. Treatment, we all know, so surgical, shunt, ventricle, peritoneal shunt. And it causes relief of most of the symptoms. Just to mention, dementia sometimes is a late sign. Going back to classification of dementia, it's going to be very important to know this for what we're going to say after that. Cortical versus subcortical. Let's start with the subcortical. When you talk about subcortical, think about something like Lewy body or Parkinsonism. So you're going to see gait abnormality, balance abnormality, swallowing difficulty, which we see more with Parkinsonism, extrapyramidal syndromes, slowing of thought and movement. Examples, progressive supranuclear palsy, Parkinsonism with dementia, Huntington disease, and small vessel form of vascular disease, dementia. For cortical dementia, the 3 A's, aphasia, apraxia, agnosia. Cortical signs are common in Alzheimer dementia and frontotemporal dementia. Some mixed patterns exist, and that one can be confusing really. Vascular dementia, 2 types, large vessel, which more or less you see with a stroke, either hemorrhagic or ischemic. The more common is a small vessel disease. Let's talk about dementia with Lewy bodies, characterized by dementia, starting with, before or after Parkinsonism, can be after like 1 year after, to show visual hallucinations, specifically rapid eye movement sleep disorder. You see the patient sometimes it can be confused with sundowning. History is very important to differentiate that these patients have movement disorder at night time. Extrapyramidal symptoms are worsened by the treatment for the dementia. And the treatment of dementia can worsen the symptoms of that Parkinsonism. You really try not to treat unless you're forced by the symptoms. present in 40% of cases of Parkinsonism. It's a subcortical type, as we mentioned. It involved impaired learning and memory, psychomotor, structural apraxia. It's more profound than what we can see with Alzheimer's dementia. Lewy bodies are intracytoplasmic inclusions. You can see it in the brain stem. This is how it looks like. Management is more or less like Alzheimer's dementia. For the Parkinsonism, you try to avoid the dopaminergic medications, can worsen the psychotic symptoms, especially visual hallucinations. Seroquel is very effective. Has a low risk for producing the Parkinsonism. Has a better safety profile than something like olanzapine, which can cause more of hematological toxicity, anemia. If you have to treat the Parkinsonism, you have to treat it dopaminergic. But you just have to be careful for the worsening of the movement disorder, especially a rapid eye movement sleep disorder. Now we go to the most important type of dementia, Alzheimer's dementia. About 1 of 2 patients with dementia will belong to Alzheimer's. A slowly progressive terminal illness can be staged into mild, moderate, severe. It occupies 4 main categories: memory, especially recent memory, cognition, planning, aphasia, apraxia, agnosia, sensory and motor, which is the last stage to show up. This is just for the sake of the technicality. Definition: National Institute of Neurological and Communicative Disorders and Stroke, Alzheimer's Disease and Related Disorder Association, uses the following categorization: possible, probable, and definite. Definite is when you see a tissue diagnosis biopsy to confirm diagnosis with a clinically probable Alzheimer's dementia. Possible, progressive course, clinically marked by atypical features of coincident, potentially confounded comorbidities. It's probable when there is a multiple domains of functionality disabling impairment, including memory loss. There is no widely used biomarkers to diagnose Alzheimer's dementia. Imaging, including CAT scan, MRI, and specific. The positron emission tomography scanning, especially in the parietal temporal areas, can be more characteristic. Other tests not routinely performed, especially it does not help with the management. Does not change the management. The apoprotein E, there is E2 and E4. More common used in the familial type. Also in CSF analysis, amyloid beta amino acids. Lower level in CSF, more suggestive of Alzheimer's dementia. The tau bodies also. That one higher levels in the imply Alzheimer's dementia. The 2 hallmarks you can see in pathology and biopsy. the neurofibrillary tangles and the myeloid plaques. The one on the left is the amyloid plaque. The one on the right is the neurofibrillary tangles. It's the most common cause of dementia, as we said. 1 of 2 patients with dementia will have Alzheimer. Increased frequency, of course, with advanced age. At age of 60%, the prevalence is 5%. The age of 85 can increase up to 20 to 50%. Lifetime risk for any of us getting Alzheimer's dementia can range between 12% to 17%. Increases with apolipoprotein E. It jumps from 9% to 29% if family members have Alzheimer's dementia and a patient or someone have the apolipoprotein E4. About 2% of the population, US, when they have studies, have the apolipoprotein E4. That these people, they have a higher chance to get Alzheimer, could be between 80 to 90%. Again, is not the standard or recommendation to check people for these levels because of the absence of effective disease-modifying therapy. The mean time from diagnosis of probable Alzheimer's dementia, not possible, probable Alzheimer's dementia to death is about 6 years. There's multiple staging schemes for dementia between mild cognitive impairment with a score of CDR for 0.5, mild dementia 1, moderate 2, severe 3. Mild dementia, there is denial in the diagnosis, what they call anosognosia. The patient is still able to function with some difficulty, with denial of this problem, misplacing objects, something you should put in the fridge, you go put it in the laundry room where you should wash your clothes. Actually, there's a very good point. Okay, there's a big difference between simple forgetfulness that we all can have, where you have your keychain, where you did this, and this is not even process of aging. Anyone can have that. The way around that is take notes if it's getting out of control. You can be busy-minded, stress, even mild case of depression can cause that. But these people having persistent problem out of their norm, okay, that's how we can differentiate it. Writing checks, going to the grocery store to do simple shopping, a process like that, they cannot function anymore. They need help from others, caregivers around them, for simple processes like that. Most tasks, again, with stress, are completely correct most of the time, but not all the time like before. Moderate, that's now more profound, more severe impairment for cognitive skills. And that brings us to the point of ADLS and ADLS. ADLS is adult daily living activity. Like what? Like toileting, going to the bathroom, taking shower, ability to fix meal for self and feed self, okay. Clothing. Okay. These people cannot do that. These people need help with that. Finance, paying bills on time, they cannot do that anymore. They need help. To add, two things can be seen here. Okay, delusion. They accuse others of stealing and infidelity. This patient are unsuccessful and living normal life anymore, and they need supervision, even placement. Patient with severe dementia, they require assistance with all basic activities of daily living. Need somebody to feed them, somebody helping them go to the bathroom, changing their diapers, somebody helping them with taking a shower or a bath. This urinary and bowel incontinence that developed in this stage according to the course. Basically, patient progressively declining from someone who is functioning all around, going to the bank, doing shopping, doing this and this, declining this independent other daily activities, then declining for normal daily living activities. Actually, there is a speech scale. This patient does not talk progressively. Patient chair bound. Patient next level is bed bound. The next level is, next thing you know, they start to have pressure ulcers. These patients are frankly aphasic. They don't talk. They must scream unintelligible words or scream sounds. Have agnosia. They fail to recognize familiar people. They cannot recognize their own children or places. During that journey, you can see the what we all know about wandering. Apraxia, inability to write or dress, loss of fine motor function, as we mentioned before, sensory and motor at the last to lose. Okay. In addition to having the memory loss. Something we noted, these patients have decreased water intake, and they come to the hospital in dehydration. They have no organic problem. Okay. We noted that when we flavor the water, okay, they drink. Okay. So we assume there is a problem with taste. This is very important, this one. Alzheimer's dementia. Okay. Medication job is to slow the progress of the disease. Okay. It does not reverse the process. Okay. Some patients, you will see that they improve, okay, but this is a minority of patients. And this is not usually it's transient. The main line of treatment is to coordinate and help the caregiver for the patient. That is the main line of treatment, even comes before medication pharmacotherapy. And to think of it, prevention, we're really limited there. From now on, you're going to agree with me. It is mainly the physician coordinating or helping the caregiver. For first item, intellectual decline, there is 2 medications approved. Okay. First one is, 2 categories approved. One is acetylcholinesterase inhibitors, Tompizil or Aricept, like galantamine or cysteamine, for mild to moderate. They help with activities of daily living and functioning. Again, the job is to slow, maybe a little bit, a few cases, show temporary partial improvement. Second category, the N-methyl D-aspartate receptor antagonist, like memantine, is approved for moderate to severe stages of Alzheimer's dementia. The question of combining medication, you try one medication, then you can add, after a full trial, you can add a second one, and you see for improvement. You watch very carefully for side effects. Next issue will be behavioral decline. That's a second goal for treatment. For agitation, you see sundowning, paranoid delusions, stealing, hallucinations, visual, mostly. There is no approved FDA drug, but the one that mostly used as what we know as Seroquel, Quetiapine. They use for patients with Lewy body dementia, Parkinsonism, example. That less likely to cause extrapyramidal symptoms than other older agents. There were two recent studies that showed lack of efficacy, but again, the dosage they used in both trials was very low. So many physicians continue to use the Quetiapine. There's a black box warning for increased risk for stroke and death with these medications. All the drugs like haldol, haloperidol had even higher risk for death. Parkinsonism, cardiomyopathy. I wouldn't order Quetiapine for a patient without ordering EKG first. If the QT prolonged, I wouldn't order it. Because it causes torsades and ventricular tachycardia. Next item, depression associated with Alzheimer's dementia and with Parkinsonism, Lewy bodies. Usually we use tricyclic antidepressants very carefully. Side effects are very common. Selective serotonin reuptake inhibitor like I won't mention generic names, I think you all know them. Also can help use agitation, but they come with a package of rapid eye movement disorder. Trazodone, one of the safely used medication in the smallest possible dose. Less side effects than other medications. And anxiety, buspirone, SSRI, they were tried initially to treat anxiety. And again, at the lowest dose. Insomnia, usually common with Alzheimer's dementia. Sleep hygiene is first thing to try. By saying sleep hygiene, you mean trying to avoid taking naps at daytime. Bed is only for sleep, not for reading, not for watching TV. No walking, no aggressive activity at bedtime. Try to minimize diuretics at bedtime. Proper pain control, and avoid medications that can cause insomnia. Antihistamine like Benadryl, many people use it for help with sleep, have adverse effects on cognition and specifically does not improve the quality of sleep. Maybe help with the quantity but not with the quality. For rapid eye movement sleep disorder, melatonin, some studies showed it could be effective. Clonazepam, again, is blamed for cognition impairment and for falls. Obstructive sleep apnea can be associated with confusional state, especially in arousal. Can be confused with mild cognitive impairment. Diagnosis is through sleep study. Treatment as you treat any case of obstructive sleep apnea, not as dementia. Urinary incontinence, common with Alzheimer's dementia. Could be one of two types. Flaccid, overflow, or spastic. You can differentiate by ultrasound. If it's overflow, what you do is offer patient frequent toileting plan. If it's spastic, you give something like oxybutynin, again at the lowest dose. This patient, Alzheimer's dementia patients, can show a abrupt decline in their mental function and physical capacity. Can be associated with urinary tract infection, pneumonia, any other illnesses. Trial of haloperidol, in one study decreased perioperative delirium duration. Lifestyle changes. As we see, these patients have safety issue with falling, safety awareness, gait abnormality, wandering. So they developed what's called safe return home program for wandering to help this patient to be found and be returned back home. How about driving? When do we tell this patient to drive or not to drive? It's different state laws. So far not the physician job. It's regulated by different states. We have the Department of Motor Vehicle, which is equal to Dr. Moore here. These patients get, in some states, exam every 6 months. Some states require that the patient does not have Alzheimer's dementia or have dementia to issue their license. And they can continue getting a temporary license sometime every 3 months or 6 months. How about gun ownership? Many people have guns in their houses. Their license can be revoked? Yes. Patients who, their family or their caregiver took the battery out of the car to prevent them from driving, solve the problem. About placement, we don't have that issue much here because of our social culture, but at one point, especially in moderate dementia, that needs to be considered. Caregiver burden. Imagine someone doing toileting, bathing, feeding, all meals, for someone screaming at them, calling them stealing something every day. Someone keeps asking the same question every 2 minutes. They tell them to do something, they forget to do it. They keep telling them to do it every 2 minutes. Can drive anyone crazy. Okay, so that's why there's something called caregiver burden. Okay? These people, a caregiver, they burn it out. So they came up with a program called Respect. Respect is basically a program where your loved one can go to a facility, go there for 2 weeks, a year, and the caregiver can take off. Whenever they like, they can enjoy the life for these 2 weeks. That is only one person getting a caregiver, which happen many times. Perhaps Alzheimer is chronic terminal progressive illness. People die out of sick leave of Alzheimer. Stages, mild, moderate, severe. Treatment, non-pharmacological and pharmacological. Non-pharmacological more important. End of life issues need to be discussed as early as possible with patient and family. Their wishes need to be respected and declared while they can, rather than waiting later when they cannot. Local organization and support societies exist and need to exist because as we see more aging population, we're going to see more cases of Alzheimer or dementia. And the cost for the community will be higher, and the burden on the community and the caregiver will be higher. Thank you. Any questions? What do we have for societies for dementia support or?
This is quite a catastrophic situation in our community. يعني السنترز بقى الجياتريك بقى وعشان بقى very expensive وعندنا سوشيال ما عندناش ثقافة الخلع العروس أو طبعا بتبقى مأساة في الحياة، مأساة في مأساة تقعد عايشة معاها.
هو أنت عنده Alzheimer dementia؟ ما يمكن. مين كان كده؟ Secret for the care for the patient is caring for the patient. Again, we're a service, not a productive sector of the community. Medicine, law, and social values are not static. We examine the ethical tenets of medicine and their application in new circumstances is a necessary exercise. That's what the ACP committee came up after 7 years. That's why they updated the manual. Our learning objectives today is not the following. Medicine is not a trade to be learned. It's a profession to be entered. That will make us different, that will make us professional. Profession characterized by a specialized body of knowledge that its members must teach and expand. We teach each other, and we learn from each other. And we expand our experience, we expand our learning. By a code of ethics. Duty of service. To serve is our job. That we should put patient care above self-interest. And by the privilege of self-regulation granted by society. We don't need anybody to regulate us. We are self-regulated. Physicians must individually and collectively fulfill the duties of the profession, while outside influences in medicine and the patient-physician relationship are many. the ethical foundations of the profession must remain in our sharp focus. There are three fundamental principles. Altruism, the primacy of patient welfare. You shoot the patient for your own self-welfare. The central trust factor. Patient trusts you, you will do that. You will choose his welfare. That is being examined or tensed, restrained by market forces, societal pressures, administrative, but still that must not compromise this principle. Patient autonomy. What's patient autonomy? Patient's right to make decisions for their own self. We should not make decisions for the patient. We're advisor. Patient decision about their care must be paramount, above all, as long as those decisions are in keeping with ethical practice, of course, and do not lead to demands for inappropriate care. Social justice. Physicians should work actively to eliminate discrimination in healthcare, whether based on race, gender, socioeconomic status, ethnicity, religion, or any other social category. You should eliminate this from your mind and from your back mind. Comes after that 10 factors that include our professionalism. Competence. Physicians must be committed to lifelong learning. It does not stop. Okay. Average physicians reads daily about 1 to 2 hours a day. If you didn't do that, you're updating. Minutes being updated faster than what we expect. Knowledge, clinical and team skills are necessary for the provision of quality care. Honesty with patients. Obtain informed consent for treatment or research. When it comes to error, report and analyze medical errors. For what purpose? We do error reporting, maintenance of trust, correction, improvement of care, compensation to the injured. That's their right. Patient confidentiality. Privacy of information is essential to patient trust and even more pressing now with electronic medical record where everybody can access the computer and the information. Appropriate patient relationship. Improve quality of care. Improve access to care. Just distribution of resources. We look for cost-effective care, providing unnecessary services not only exposes one's patient to avoidable harm and expense, but also diminishes the resources available for others. Ordering unnecessary tests does that. Scientific knowledge. How to manage conflict of interest. Medical professionals and their organizations have many opportunities to compromise their professional responsibilities by pursuing private gain or personal advantage. We all face that question every day. Such compromise are even threatening with for-profit organizations. Though it's not without a question for non-profit organizations. Physicians have an obligation to recognize, disclose and the general public and deal with complex interests. All right. I have nothing to disclose. Just to mention. We all have professional responsibility to undergo self-assessment of all aspects of one's performance. We self-regulate, we follow ourselves, and discipline ourselves. Over decision making. What do we know about the patient ability for making decision? There is two things to know. There's competency and there's capacity. Competency is a legal term that usually is granted by a judge in court. If the patient is competent or not competent. Capacity is more of a medical term that can be evaluated by a physician, a psychiatrist, a neurologist, or even a nurse. It's very simple. The patient, if you want to determine the patient has the capacity, they know what are the options, they can make choices, they know the consequences, willing to accept the consequences. Okay? Example, a patient is handicapped, in a wheelchair, in a house, have stairs, no ramp to that house. So if there's a fire comes in, he will not be able to get out of the house. He decides to live in the house. He knows his option is to live into another house with a ramp or go to a lower floor where you have no stairs. He chooses still to live in the house. You know, the consequences can be that he can die, and he accepts it. At the capacity. Patient comes to the ER with hypoxia. He knows he needs oxygen. He might die if he does not stay in the hospital to get treatment. He is upset because he's been waiting for the doctor for a long time. He knows that if he leaves without being treated, without getting the oxygen at home, he might die. He signs the paper. He won't take the risk. He goes home. I have a patient who did that and he died. Not my patient, but I've seen the case. Informed consent, thesis, communication, comprehension, and no correction. Disclosure of all relevant information. If somebody have seen an informed consent for any surgery in US, long page, usually 2 pages. So are you going to read all of this to the patient? Well, it's mainly you tell the patient the necessary information that a reasonable person will need to know. Withholding or withdrawing treatment. When do you do that? It's a patient preference. Justifiable, both an ethical and a legal perspective. End of life issues are to be discussed with the patient as early as possible. This is the job of the primary care doctor, the internal medicine doctor, who know the patient best, who know the patient from before, to discuss this issue with the patient. Quantity versus quality of life. The job is still about end of life issues. That point.
الكواليتي ده والكواليتي دي العيان اللي بيحدد الكواليتي بتاعه يعني not resuscitate. انت اللي قررت ان الكواليتي اوف لايف از ميزربل للعيان، فقررت انك انت مش هتعمل حاجه تانية. هو بالنسبه له هو this is a good quality of living. مين بيحدد الكواليتي؟ احنا اللي بنحددها. الديسيجن ميكنج نوت resuscitate، وده مش حقنا. الكواليتي دي بتاعته هو مش بتاعتي انا. انا ممكن من وجهه نظري ده عايش ازاي، هو شايف ان الحمد لله وانا عايز استمر.
Absolutely. What did he say? The one in the middle?
autonomy.
Autonomy. Okay. Your job, my job is to advise. Okay. Let me give you an example.
يعني العيان ما بيتحطش على الفنتليتر، ما بيكونش ده قرار الطبيب. لما يكتب البلوك ريسيسيتيف ده قرار طبيب مش قرار
Let me
العيان.
give you an example. Okay. Patient with breast cancer. Okay. Terminal. Okay. Patient doesn't know that she has terminal breast cancer. She thinks that she has arthritis. Is that appropriate? Okay. Now, patient have metastasis to the liver, causing coagulopathy. Okay. And now patient is bleeding, hemoglobin is 3. Patient being given FFPs, fresh frozen plasma, given blood transfusion on daily basis for a month. That's appropriate? No. Okay. What happened here? The breach of patient autonomy. Right? That when you have to tell the patient, you have a terminal illness, you're going to die no matter what we do. Right? And the patient has to choose. If the patient wants to get blood transfusion, fresh frozen plasma every day, knowing that by the end of the day, she's going to bleed again, patient choice. We should prepare to go home and die with family as their own environment. And patient choice. Patient autonomy. We're not God. That's all I tell my patients. I'm not God. I might get out of here and get hit by a car and die. And this patient might outlast me for several months. Right? I'm not saying I'm gonna die tomorrow. I don't know. Right? But I'm telling you, whatever I'm doing is not gonna help you. It's not gonna make you live longer. Right?
بس مش محتاجة لوز، أنا محتاجة أصل عشان كل situation بتبقى very personal.
Our job is to provide the information that we know. And the patient make their own decision and their family with their family.
هو في توقيت بيبقى هو so helpless لدرجة إن مش بتاع الديسيجن ما بقتش بتاعته يعني هو ممكن يكون مثلا in state of delirium، in state of أي حاجة هتقعد تكلمه إزاي وهو delirious ولا confused ولا عنده delusions ولا يبقى العيلة هي اللي بتقول الأوتونومي بتاعه مش هو الأوتونومي بتاعه، ده العيلة هي اللي بتقول لك يعني أنا هنقول له أنا أديك باتش مورفين وتروح البيت ده ترمي. عمره ما بيكون عيان.
Look at that. Any of issues need to be discussed as early as possible.
ما هو برضه مسألة أكاديمه بدري دي صعبة جدا. ده إزاي يعني العيان لسه حاسس بنفسه ها at that stage I'm fine. وأنا جاي أكلمه وأقول له معلش بقى أنت خلال 6 شهور هتموت عشان أنت عندك بتاع. وبالتالي ايه رايك بقى لما يجرى لك انا قلت ده حوار ممكن يستوعب يعني وهو كويس.
That's right. That's why you go back here. Patient autonomy.
برضه
I'm not God. I cannot make decision for a
يعني
patient.
حضرتك ده ethics ولا ده عشان تجنب يبقى ايه؟ خلصت انا قلت اللي يعني انا كده ما حدش هيحاكمني، ما حدش هيرفع عليا قضيه بعديها بيوم.
Absolutely not. The
I'm not
question
gonna
is,
be sued. انا قلت لك.
the question is, should I be God and take the parental rule and take decision for the patients, or should I use my profession, okay, and be a more professional and just share the information, my professional information with the patient that he came to me, coming with rule number 1, altruism. I'm gonna look for patient number 1. Okay. first benefit for the patient. And then rules number 2, I'm using patient autonomy. Okay? I'm giving them my role as an expert. They came to me as an expert. Okay? They didn't come to me as a father. Okay? I'm not making decision for them. Okay? My job is to tell them the information they came seeking from me. Okay? And help them make that decision. I can help to make a decision. I'm not withdrawing myself from that decision making. Okay? I support them for reaching that decision. I'm more than happy to provide any information they will ask. I provide them any advice I will ask. I even say that, you know what, if my father will do that, if I'm in your place, I'll do that. Okay? I'm going that extra 9 miles. But am I going to make a decision for the patient? Should I? Absolutely not. Imagine that. That patient I know, she died. Not even that she is dying. That's unhuman. Regardless of unprofessional. It's very helpful for the patient to declare their wishes early and then directives. Someone have delirium, have depression, suicidal, in the ventilator, can make decision. What we have is medical power of attorney. Someone is legally assigned to make decision for them. Someone say that I want my wife. If I'm in the ventilator, I cannot make decision for myself. I want my wife to make decision for me. Someone say, I don't want my wife. Someone say, I don't even want my children to know that I'm sick. We just respect patient autonomy. Even that someone with dementia, they lack the full capacity to make decision, but with help with a family member or a friend, that friend or a family member can be what's called a surrogate, a helper for decision making. Physician-assisted suicide and euthanasia, bottom line, not to just keep going that, it's illegal, unethical.
تديله overdose ولا حاجة عشان يتكل على
That's illegal, that unethical. There's 2 states. Yes.
ان احنا كده يعني هيحصل له respiratory depression and it is acceptable we have to end this مصيبة this.
سالوا في السويد يا مهدي مسموح به.
مسموح بها في هولندا؟ Yes,
There's 2 states in US that take that as legal, but again, both American College of Physicians and American Medical Association have issued statements opposing that practice. It's currently illegal in all states except Oregon and Washington. So it's illegal, meaning if you do it, you go to jail.
في هولندا مسموح بالقانون.
Illegal? No. You go to jail if you do that.
لا في أمريكا عندهم، في هولندا لا.
I'm not. Going back to in the blood issues, these patients very commonly be in pain. Pain need to be addressed. Problem. Someone dying should not die in pain. Their last days should not be spent in pain. The maximum dose is morphine. Okay. With this kind. There is no maximum dose for morphine. You can give morphine, later increase it, separate up as needed. Still, we don't see that. Yeah. barriers. Oh, patients do not want to be addicted. I've seen many patients here and in States. They decline taking narcotics. Then they have legitimate cause to be in morphine or hydrocodone, just because they don't be addict. Even though they be dying in 3 months or 6 months.
المورفين ما بيعملش ادكشن لو انت بتديله في حالة بين. يعني هو لما المورفين بيتاخد من غير بين ده اللي ممكن يبقى ادكتد.
Actually, there's a very interesting
لما
study.
يكون في بين العيان مش هيبقى ادكتد. so long في بين.
That's absolutely true. Absolutely true. Actually, there's a very interesting study. They found that the chance for someone to be addict from narcotics for pain control in cancer patients, if they have no history of addiction before, 0.007%. 7,000%.
هو لازم يعرف المعلومة. يعني العيان ممكن يجي لك مثلا عنده عين معين وانت عارف تشست بين وانت لازم تكون عارف معلومة إعلامية انك انت لو عندك
Absolutely.
بين انت مش هتبقى قد.
That's why we're discussing that to spread the information. The other barrier, even worse, is physicians who are not allowed to prescribe narcotics for legal issues. They're afraid that if they give it to patient is going to die. Lack of training, lack of education, lack of legal information. Actually, the American College of Physicians and many states now putting laws to or regulation to encourage physicians to prescribe more narcotics to cancer patients. Till recently, it was the opposite. They were going too tight on physicians, physicians going to jail for prescribing too much narcotics. Now, they're encouraging to prescribe it for cancer patients. Confidentiality.
ده ينطبق على مبارك بقى.
That topic is about a patient.
ينطبق على مبارك ولا لا؟
That
مبارك في
topic,
وضع خاص.
that topic is example for it. A patient I know, her mom in the hospital elevator happened to witness 2 residents discussing her daughter in the elevator in front of her. Absolutely unacceptable. I cannot discuss patient condition with any family member without his approval. A mom comes to me, okay, asking me about her son. Her son is 4 years old. Okay, her children, family. Asking me about information about the patient. Should I go ahead and tell her, or I should wait? Ask the patient first. What does he want me to tell? What he does want me not to tell? By law, I wait. I ask the patient first. And I've seen patients say they do not want their children to know anything about them. They're in bad relationship with their children. Sometimes family member can have financial gain from knowing this one is sick in the hospital or gonna die or something like that. Or the other way, some family members can have gain from patients staying in the hospital for a prolonged period of time. There is a law, I don't like it. Nobody like it, but everybody has to follow it. Okay. Called HIP. That came at Bill Clinton. Okay. Health Insurance Portability and Accountability Act. By this law, physicians can end up paying, that's the most severe case, right? Paying $250,000 and spending time in jail for up to 10 years. That's when you sell patient information to somebody to gain benefit, financial gain.
بيسرب تقرير تقرير صحي بتاع حد.
Different causes. But That's something can really happen, but it exists. When I pick up medication from the pharmacy, I have to sign that I'm releasing them from that law. Confidentiality is a legal issue that there is laws and regulations that exist and need to exist for protection of patient rights. Examples. HIV. Okay. Patient comes in, have complaint, you do HIV testing, come back positive. Should you disclose or you should not disclose? I mean, should you tell the patient wife, not married or married or have other sexual relationship with other people? Should you disclose it or not? Yes, should.
هي في الاتش اي في ده واضح اصل ده مساله بقى ايه هو جاي عنده ايدز مش عايز مراته تعرف طب ما هو لا يعني في
بالظبط بالظبط. should disclose. should disclose.
بعد ما اكون انا استنفذت وسائلي في اقناعه انه لازم لكن لازم اقول في الاخر
Yes.
انا هبلغ.
Yes. Okay. You should disclose by court order or police. Okay. For someone threatening to kill somebody, go to psychiatrist. Yes. Someone come in full of bruises, or a child come in full of bruises. You think domestic violence, someone beating the wife or someone beating the child. Yes. For the child, by law you have to report.
بس الست لا.
If you don't within 48 hours, I think, different states, different regulations, you can be even go to prison. For wife, you discuss with the wife.
وانا ما بلغتش عن العيل مضروب انا اخش السجن.
لو ما بلغتيش.
لو ما بلغتش.
ما بلغتيش. Reporting is important for children. They cannot protect themselves, but the wife can protect and then
طبعا في ميسيوز للعمليه دي بالهبل برضه يعني انت بتقولي جانب المفتح بس.
Some
ميسيوز للقوانين دي.
Think of it. Okay. Child abuse can end up with death sometimes. مش بيتكلم على عيل ضرب ابنه بالقلم، حد ضرب ابنه بالقلم. You talk about real child abuse. Someone with rib fractures, someone with subarachnoid hemorrhage, things like that. It's a crime not to report. That child cannot report himself. Again, they come to you for protection. Gunshot wound. You should report it. You have to report it by law. Minors versus teens, pregnancy in minors, very tricky issue. We have different culture. We go by our culture and our religion. Okay? Record keeping. And comes along with it responsibility for caring for your patients. Okay. I'm taking care of this patient in the hospital. Right? في عيانين بتوعي في المستشفى وأنا هنا دلوقتي. Who care for them? Am I responsible for caring for them? Whoever say I'm responsible, please raise their hand. One thing. Okay. But the rest don't think I'm responsible for them, right? I am responsible for them. I'm their doctor. Guess what? I violated that first rule. It's not the first rule for nothing, because it's the most important one. That one came to me, trusting me. Okay. I leave them in the hospital, sick in the hospital when they need me most, and I go to the beach. That's appropriate? No, absolutely not. I have to arrange for coverage. I have to arrange for another physician to cover for me. That's what we do. Okay. in the hospital, in the clinic. Usually patients prefer to wait for their doctors when they're back, when they're available. But if they're sick, they're sick. Someone has to take care of them. And this needs to be done professionally and properly. Okay? And that's what we do. Conflicts of interest. And by the way, for record keeping, I work in Texas state. According to the state regulation, I have to keep record patient charts in the clinic, and the hospital have to keep record for the patient charts. Even if someone retired, okay, I have to keep record of the charts. I pay money for that. For a reasonable period of time, from different states, okay, till the patient have arranged for another doctor. Conflicts of interest, I'm giving a lecture, I'm paid for by a pharmaceutical company, I have to disclose that. I am in the clinic, medical representative come to me, give me a gift, offer me dinner, myself, my family, even a pen. I should know. I should avoid that.
المفروض يكون قانون محطوط، يعني انتم مش قادرين على الميجا يعني شركات الادويه الميجا ما تقدروش تحطوا legislation تقولوا ما دام النتيجات دي ممنوع، مش تعرضني انا للتمتيشن وبعدين تيجي تقول لي انا هحاسبك انت، لا حاسب، لا من المجمع بقى الشركات دي ممنوع كذا وكذا 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 كلهم سبمت.
And there is laws for that. But still, it's my duty to say no.
دي بقى مطبقه فين الناس دي؟ لا مش مطبقه.
These laws are international, okay? But for example, American original American pharmaceutical company and the origin in the United States, the laws apply outside, the same laws on them. Okay? So they're prohibited from doing things illegal. But we're not talking about that. We're not discussing that.
هيسوق ازاي منتجه؟ ولا حضرتك هو ما بيعملش الحاجات، هيسوق ده منتج، ده مش حاجه فيدرال الحكومه يمسكها. في الاول وفي الاخر
Absolutely not my job. And I don't care about it. That's their job, that's their problem. My sole duty is to my patient. And I'm not going to violate that. I don't care if they give me a pen, I don't need it. Give me a dinner, I don't need it. Okay? I care about my profession more. I make better money from caring for my patients than what they can offer me. That's how it ends.
طيب ما تاخد البن وما تكتبش ده وبتاع، ايه مانع في كده يعني؟ يعني واحد بيقول لي خد القلم ده وقال لي قال لي ليكتشر مثلا او في برزنتيشن وبعدين اداني قلم، هو ممكن انا اقول مش هكتب ده اللي يعجبني، ده انا شايفه ابروبريت للعيان.
يعني هو الكاميرات اللي بتتعمل مش دي تحت رعاية شركة دراكس ولا شركة مش عارفة ايه، عامل مؤتمر ومكلف فلوس وغدا وعشاء وإقامة وبتاع، مين اللي بيعملها؟ ده هتخشها في ده ولا لا ده موضوع تاني؟ وهو بيكون بيسوق حاجة جديدة. الثيرد جنريشن U6 جنريشن وفورث جنريشن.
We have that. Okay. As it disclosed. Okay. And as long as they disclose it, okay, right? I do not prescribe their medication because they offered me the dinner or organized the lecture. Okay. It's well known and well respected. That I come to give a lecture paid for by pharmaceutical company, and I'm in their favor at the end, bottom line, at the end of the lecture, I'm in favor of their medication. It's a research they done and they paid for, and I'm promoting it. I'm promoting it. And they offering dinner to everybody here. that. This is disclosed everything before the presentation. And when it's disclosed, okay, and we know about it, there's no tricks here. Yes, this is acceptable. What medical error reporting? There's a very interesting point here I would like to share with you. Okay. Look at it. At this point, this was included one of Bill Clinton's speeches. Okay. This exact number. In 2000, nearly 100,000 patients died as a result of medical errors each year. Imagine that.
Okay.
Huge number. That number that is the population of a country. Okay. Brigham and Women's Hospital, okay. One of the best hospitals in United States. Okay. They did self-audit. And the beauty of it, they declared it. Okay. That's how we know all about it, okay, right? Then in 2005, they found 233 serious errors. 54 of it are preventable adverse events during 1,490 patient days. The most common, let's analyze it.
1490 نقول 1500
Patient days. Patient days.
233
Patient days, okay? No patients. Okay? That's how long that, so it can be one patient stay 1 day, so that's 1,490 patients. Or it could be out of that number for patients stay 2 days, okay? So it's tricky. But let's see what exactly that number is. Okay? The most common serious error were medication related, 61%. Okay? Medication error related, you cannot be faulted for it. Okay? Someone taking medication, develop side effects, like someone get anticholinergic, they get confused. 53 of performance level failures were slips and lapses. They were not rule-based or knowledge-based error. They were not because of lack of knowledge or a systematic error. That's something that keeps happening. Okay. Look at the next one. Okay. 2/3 of adverse events do not cause direct harm to the patient. Okay. Many of these errors were near miss, but not a real miss. Okay. But they self-reported. Preventable errors cost approximately $20 billion in hospitals alone, not in clinics. So they did what? They did a root cause analysis. Okay? That's how we reach for medical errors. That was called quality assurance. That's a job, quality improvement. Okay? So, is this patient assessment fault? Staff training not happening? Equipment related? Okay. Work environment not safe? Lack of information? Misinterpretation of information? Communication error? I said something, somebody didn't hear me well or didn't understand it well. Rules, policies, procedures. Failure of a barrier designed to protect the patient, staff, equipment, or environment. Personal issues. I don't like the patient. I don't like the other doctor. They found that most of errors happen because of this. A Swiss cheese error. Garber and Lee studied factors that contributed to diagnostic errors in 100 cases and found an average of 5.9 system-related or cognitive factors contributing to diagnostic error in each case. This finding confirmed the Swiss cheese model of error in a medical environment, that there must be a breakdown of several layers in the system to actually cause an injury. Okay? A medical error is not caused by one single problem. Okay? For this to happen, okay, there's several barriers they have to prevent error from happening. Okay? So for an error to happen, a bunch of people must cause a failure in the system or didn't do their job. That's what I just said. Built-in multiple layer protection between a patient and any potential harm. Okay. What is the average ratio patient to nurse in the floor? The average ratio patient to nurse in the floor. يعني الممرضة بتاخد بالها من كام عيان during her shift. في الفلور لا على عندك
الممرضة 30 عيان.
ها؟
الممرضة 30 عيان.
1 to 5 1 to 5 عيان تاخد بالها 5 عيانين. الممرضة responsible for direct patient care time 30% of the time.
يعني في العنبر عندك كل ممرضة مش كل 5 عيال ضحك.
Next
طب وحضرتك
نوع البيت
الريسبونسبيلتي بتاعتك بالنسبة
my average census is about 15 patients.
ايه؟
15 patients a day. My average census patient caring for in the hospital about 15 patients.
15 ده متابعة ولا كعيادة
Half.
ولا
Going back to the nurse. Nowadays, the norm is 30% of the nurse time is allocated for direct patient care. تديله دواء بتقيس الضغط، في الحرارة، تديله حقنة. Okay? Examining the patient, 30%. 70% of the time, you call it administrative, you call it quality improvement, but that's a nurse job. They're doing quality improvement. 2/3 of their time, they're doing quality improvement. That's the difference between a hospital and a hospital. 1 to 5 is high ratio. I work in other hospitals, average 8 patients. In the ICU, the best is 1 to 1. I've seen 1 to 3. Hold on. That's St. Louis. Okay. Next hospital, Methodist. Okay. 1 to 4. Okay. But still, St. Louis is a better hospital. That's what everybody's saying. Okay. Because they have a better quality of care system, okay? Better quality improvement system. Okay. What these nurses are doing, okay? Why are they doing that? Okay. Better quality of patient, less cost, okay? They're doing what? Like the air pilot, okay, cockpit, before they go up, fly, okay. They have checklists, right? We all know that, right? We watched the movie, right? We watched the movie? Okay. Same thing. Intensive care unit nurses, okay. They have their own checklist. For infection control, prophylaxis, ventilator weaning, sedation holidays. They don't give sedation around the clock in the ICU. They give holidays near the morning because if the patient is already being intubated, they can be extubated. They can be extubated. Carrying out the wrong amputation for the wrong limb, taking out the wrong kidney, operating the wrong side, whatever it is, they do what's called timeout. Who's the one doing the timeout in the ward? The nurse. Okay. Making sure this is the right patient, this is the right side, okay. All the tools and towels are taken out of that patient, right? Double. Okay. That takes time. So the nurse cannot take care of 30 patients doing that. We need to give her, allocate more time, we need to give more quality. Okay. Saving time. Okay. I apologize, I'm going to take from your time a couple more minutes, okay? We have something called core measures. Okay? The government came up with that core measures, basically saying, if you follow these core measures, we'll pay you more money. If you don't follow it, you meet this criteria, we'll give you less money. Well, it's all about money. We all work for money, we all work for free. Hospitals, doctors, everybody. Right? So one of the core measures is congenital heart failure. Okay? They came up with the hospital themselves. Okay? Right? They came up with comparison with each other, and they came up with a study. See if they're meeting this criteria and they're making money from that or losing money. The government pay the hospital their money if the patient stays in the hospital 5.3 days. Okay? If the patient stays 10 days, 30 days, give you the same amount of money. Right? If the patient comes back within 30 days, that's called readmission for the same reason. Okay? They don't pay you for the second admission. Okay? So that's negative incentive. So you want the patient to stay less than 5.3 days, right? And you want the patient not to come back, right? So in the hospital, they did a good job. They showed the patient average 4.6 days. Some did 3.5 days, something like that. At the end of the 2 years of the study, they found that hospital that patient stayed for 6 days, 6.5 days, they made more money. How? Because they did better job taking care of the patients. The one that discharged patient early, they got more penalized. Higher rate of readmission. So they didn't stop there. They studied why, the readmission rate. So they found ER doctors, hospital floors doctors, nurses, patient education, including, okay, not giving aggressive diuretics in the ER, okay, at the early stage, okay, to break the cycle. No patient education. Okay. You want to treat this patient? At time of discharge, educate them. Okay. Tell them, I want you to follow your weight. If you gain more than this weight, you increase your diet by yourself, and you go to your doctor within a week. Okay. If this is not happening, you have to come to the hospital. Patient does not want to come back to the hospital. So mostly patient will follow. So you give them verbal information, education, give them writing. Okay. And guess what? The VA, Department of Veteran Affairs, okay, they type their brochure for patient education at level 4th year level of education. So they treat their adult patients as if they're 4th grader. Okay? So we have no excuse saying that our patient doesn't know, patient has no knowledge. Let's do it. Okay? Smoking, okay? Salt intake, okay? All of that is education. Okay? That's what the nurse, when she had a patient with speech health, okay, is doing with the patient. So all these 10 hospitals started for another 2 years studying when they followed these rules, did education for the nurses, did education for doctors, did education for the patient. Okay? They found they saved $500 million. I'm sorry. $500,000. My husband. Over 2 years. So by giving the patient more time, they save more money? Yes. By giving the the nurses, less number of patients and more work to do, proper job, they save money? Yes. That's how these people think. Okay? They're not stupid. They're not throwing their money on the floor. Okay? Think of it. When patients spend more time, they're spending in the hospital, they're spending less time at work, so less productivity. Okay? These patients have a higher readmission rate, so that you and me at the end are paying extra money for their care unnecessarily in the hospital, expensive. Okay? I don't know what the cost of the patient stay here in the hospital, but average in the US is about $2,000, $3,000 a day. So, by keeping the patient away from the hospital, you're saving money to the patient, to the hospital, the community, the government, for the taxpayer, for you and me. What improvement? Plan, do, study, act. I was myself amazed when I read this. Okay, it's in the again the ACP ethics manual. Okay. Forget about all that. Okay, we will know about it. Okay, it's legal and ethical, blah 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 blah. Right. Okay. During the patient contact, even regardless whatever duration, have lapses since you have seen the patient last. Forget this stuff.
5 to 10% of psychiatrists.
Is by this profession
That's
have been reported.
with the people.
These people who reported, never mind people who did not report. Okay, 15% of psychiatrists have had sexual contact with the patient. Okay? These are just psychiatrists. Internist, and surgeon, blah 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 blah. Patient is vulnerable in their doctor. Patient is dependent on their doctor. Patient is weak. Okay. This is an issue. Okay. America, okay, but I don't know. We're going to stop here. Okay. When I examine a lady, gynecological exam, something like that, I ask for a chaperone. Okay. And I ask for the chaperone to be looking at me, not looking anywhere else in the room. I get very angry. She doesn't need to exist if she's looking somewhere else. Period. Okay. This is to protect me. Okay. And this is to make the patient feel safe. And during that time, I'm careful. I don't discuss anything personal that that chaperone does not need to know about the patient. This is also something that
يعني النيرس بتاعتك ولا
anyone.
ولا أي حد يعني
أي حد.
الدكتورة اللي بره بتاع المهم يبقى فيه حاجة.
Any female.
Yes.
It makes everybody happy. It makes everybody comfortable. A third position. Who's a third position? Someone retiring doesn't want to retire and continue to work. Okay. I have a friend who's 85 years old and still practice. Temporary reversible causes of impairment could be drug abuse, could be alcohol, could be schizophrenia, bipolar disorder, whatever it is. That categorized myself as under some sort of impairment. Look at that. Yeah, doctor, high stress, psychiatrist, solo practitioners, doctors who work in the clinic by himself, compared to doctors who have worked in large groups. These people have higher risk. male sex, female doctors are protected. Yeah. So, what's our job? Should we report, not report? Okay. What about rehab programs for this doctor for substance abuse, alcohol abuse? They found doctors have higher chance to recover from substance abuse or alcohol abuse, higher than the general population. And the average is inpatient program for 4 weeks. Reporting can be to hospital or for us city regulation. أنا ممكن نختلط البعض أو وزارة الصحة. But someone needs to be reporting. Absolutely, it's underreporting, of course. Nobody wants to report a colleague, unethical. Think of it. Okay? We're afraid of they coming back at us. Okay? We're afraid of they come back accusing us of something else. So not really being done properly or as it should. What do you think of that? It's tricky. كان في دعوات للإضراب في مصر وفي إضراب جزئي اتعمل I think twice, right? مش كده؟ كان very aggressive call for the strike. I asked the people, do you have an alternative plan for caring for your patients during the time where you're doing a strike? I never got an answer. 3 people who organized that strike never planned for alternative plan of care for their patients or wherever they're providing services at the time of strike. All they think about the strike. Okay? It doesn't mean it doesn't happen. بيحصل في إسرائيل. على فكرة إسرائيل جيراننا أكثر دولة تعمل سترايكس. قعدوا مرة تقريبا 3 أشهر و6 أشهر. وبارشل سترايك.
وخلوا دي شغالة يعملوا سترايكس في
بارشل حتى المستشفى كمان شغالة.
هو الفكرة يا دكتور بس ان لو السترايك ده بيتعمل عشان هو مش عارف يقدم، حاسس ان هو مش عارف يقدم له اللي المفروض يقدم.
أنا معاك والله.
فهو أنا اوريدي برضه بموته وأنا شغال.
Let me say one more thing, add one more thing. تبع دكاترة أمريكان. They're making good money. But لما تيجي أنت بتشوف عيان and they're telling you you're gonna لو بتاخد 10 قروش على العيان ده أنا هديك 6 بس. 5 منهم هيروحوا في مصاريف إدارية. Now, many physicians, especially primary care, either retiring early or changing their practice. And it's a problem. Still, the American College of Physicians, I'm saying, should not include persecution joint actions. You can do marches, you can do lobbying, and they're doing good lobbying actually. But for example, that law to cut the payment for physicians by 2/3 has been so far postponed for the last few years. Sometimes it's being postponed by lobbying for the last minute. Sometimes after the due date. Actually, last time it was postponed, and doctor will pay it according to the lower pay for I think a week or something like that. Then the law was signed by the Congress after that by lobbying. And doctors saying we're not going to see these patients. Okay. Then the law was signed and they pay doctors back the difference. Okay. So I'm just stating what the American College of Physicians say. The point is not what they say. The point they are saying something. Okay? They studied and they kept saying something. Okay? What we need from our professional organizations have a say. Okay? A declared statement right? But what physicians should do? Strike, no strike, okay? With respect, okay, to physicians, right? To be protected when you go on a strike. You have to be protected, right? If I should not go on a strike, then they don't protect you, right? And you're in the middle between your job and أو ده الصح. When you're going to strike, what about the patient? Okay. The patient needs to be taken care of. Okay. You cannot go into a full strike. That's not accepted anyway. Okay. You have to go on a partial strike. Okay. Effective, yes, but you have to arrange for care for the patient. Okay. If they're going to take integration of more than one entity like the الأطباء ولا الصحة الجامعات التعليم, yes, but this needs to be done properly. مش بصورة ارتجالية زي ما شفناها قبل كده. That's the take home message from this. Again, these people keep studying this for several years until they come out with this. أنا متشكر جدا لوقتكم وحابين say إن أنا سعيد جدا إن أنا النهارده معاكم و the chance to be here is a privilege. شكرا يعني لكم وأرجو إن أنا أكون